Ooh, the music went off, so that means we get to begin. So thank you so much, everybody, for joining us, and I'm sure there'll be a few more people trickling in. I'm not going to lie, I'm totally jazzed about this whole provincial showcase that we're doing, research showcase over the month of May. I think it's brilliant, but I'm secretly like a smidge biased towards our Fraser Health sessions. I don't know why. To introduce myself, I'm Kate Ketchum, the Director of the Department of Evaluation and Research Services at Fraser. And I get to work with this awesome team that gets to help our awesome frontline clinicians and staff to do research within the health authority. Today's session, of course, is about COVID. I think we've all heard of that before, right? COVID, yeah, it's a thing. And so we're going to showcase a few of the cool projects that have been underway the last while. But a fun fact is that currently there's over 100 COVID studies that are happening within Fraser Health, which is pretty cool. But enough about that. I'm going to, because I just remembered that I am the one controlling the slides. I want to absolutely, with much appreciation and recognition, say that I'm privileged to be participating today. Fraser Health, we work, play, and live in the unceded and traditional shared territories of the Coast Salish and Naklapma First Nations, and I'm coming today from Burnaby, staring out at this beautiful mountain, which is the Squamish, Musqueam, and Tsleil-Waututh. I have now also lost all visuals of you guys, so now I'm just going rogue. It is a jam-packed schedule, not only for this session, but also obviously across the board if people have been attending all the awesome sessions that there are today. So a bit of a housekeeping thing, we're going to ask for questions. We have 3 presentations today. We're going to ask for questions to come at the end. So you can either put them in the chat or wait, but we're going to ask for all our awesome presenters to go sort of 1, 2, 3, and then we'll do questions. And then this is a plug, a really cool thing that came out of COVID. The BC Biobank Network is a living and breathing thing. And I wanted to do a plug to say, should you have had COVID before and are interested in providing a sample of your blood to this biobank, please do. Fraser Health is one of the health authorities that is contributing to this. So that being said, I feel like I want to say, Javier, you are our first up to bat. And so I feel like I'm going to stop sharing and then get you to share. And then we want to hear from you.
Okay, can you see my screen okay?
Yes, we can. It's great.
Okay, sorry, I can't see you anymore. So just let me know if there are any difficulties with seeing my screen or hearing my voice. And if there are no difficulties, I'll start. My name is Javier Sahota. I am a clinical nurse specialist working with the Fraser Health Regional Access and Flow team. I am here to present on our COVID Care at Home project. This was a quality improvement project, so not a formal research study, but very exciting project. And so this is the work of many partners. It was a rapidly implemented and developed and implemented project where we had many partners who came together, including our Regional Access and Flow team, home health, virtual health, community respiratory services program, our hospital medicine regional leadership. So many of our physician partners came together, all the medical directors, appropriate medical directors also came together. So I have listed some of the names on the screen. So these were the operational and clinical leaders, but this slide does not mention all the clinicians who participated in this project to make it a success. So I just want to give you some background on why we started this project. So as I work for the Regional Access and Flow team, our focus is on the coordination of hospital flow activities, really focusing on decreasing congestion throughout Fraser Health. So this project actually began during the second wave of COVID. The first COVID, we didn't see an increase in hospitalizations, but the second COVID wave brought increase in hospital visits and admissions. So hospitals were getting congested, and the length of stay for the COVID patients was increasing as well. So as we were losing capacity, acute care capacity, it really led our clinical and operational leaders to ask, what else can we do to decongest our acute care sites, especially for the COVID positive patients? And so there was a meeting that was held at the regional level with the physicians, and basically the lead physician, Dr. Mike Boletta, who asked the physicians, what's preventing the physician's ability to discharge COVID positive patients? And they had expressed that some of the COVID positive patients, sorry, I just lost my screen, just need a little bit of oxygen, and that could prevent their ability to discharge these patients. So these patients ended up needing oxygen for quite a long time. And when we looked at the literature, we also found that 15% of the patients with COVID-19 who require hospitalization need oxygen support that could continue on for months due to respiratory dysfunction. So this led to the question, can we provide care to stable COVID positive patients other than the acute care setting? The average length of stay for the regular COVID positive patients, not the long hauler, was 16 and a half days. And the ones who ended up needing oxygen for a long time, that length of stay could be weeks. So then, we brainstormed a lot of solutions, looked at a lot of projects or programs and services that we already had in Fraser Health to see if we could leverage any of those programs. So in the end, it was decided that we will use our current community respiratory services program to provide home oxygen support and remote monitoring support to COVID-19 patients still in the recovery phase of COVID. So just to give you some information about our community respiratory services, this is a regional Fraser Health program. It's made up of 17 registered respiratory therapists that provide care to patients on home oxygen, tracheostomy, and chronic respiratory patients. The CRS, as we call it, Community Respiratory Services Program, these RTs do in-person visits, telephone visits. They provide respiratory rehab, tracheostomy care, self-management education, and remote home monitoring to COPD patients. So that seemed like the most appropriate program to use to decrease the length of stay of COVID-19 patients in the hospital. So as we were using quality improvement methodologies, we came up with a clear aim statement. So our aim was to safely discharge non-frail COVID positive patients on low levels of oxygen. So low was determined to be between 2 to 3 liters per minute, initially at least, with home monitoring to reduce hospital COVID length of stay and congestion. And this program began in April. So these were the program goals and outcomes. Our goal was to correctly identify and safely discharge appropriate COVID-19 patients requiring oxygen therapy, reduce overall hospital length of stay of COVID-19 patients, and increase acute care capacity, demonstrate safety. So safety was our #1 goal. So we wanted to prevent any adverse events during this time and unnecessary readmissions back to the hospital. We also wanted to improve the patient experience while recovering at home. And we wanted to ensure the provider satisfaction with the program. So as I mentioned before, we use the quality improvement methodologies. This is the model for improvement. We looked at the 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? So we did many PDSA cycles to implement this project. And as I mentioned, this was a quality improvement project. So, we really looked at the accessibility, efficiency, effectiveness, and really patient safety was our #1 concern. And when we looked at the literature, we wanted to really find out what type of criteria other similar programs were using worldwide to provide home oxygen support in the home while the patients were still recovering from COVID. And based on the literature search that was limited as well, and our own experience, we came up with these criteria. So we carefully selected these patients age 70 or under, not frail prior to hospitalization. These patients, we wanted to make sure that these patients were never intubated because we were looking for stable patients. Symptom onset greater than 10 days, stable or decreasing oxygen needs. So at that time in the initial phase, we looked at the maximum oxygen level of 2 liters per minute for 3 days at least, but then this was eventually increased. Able to manage self-care or require minimal home supports, and patient had to consent to participate in the program because this was an expedited discharge. And we wanted to make sure that there was somebody in the community to follow up on these patients' care plans. So a primary care provider was required. And then, of course, because of home monitoring, remote monitoring, we wanted to make sure that the patients had a home with telephone access. So in regards to quality improvement, usually the idea is to start small, test the changes, but because of the urgency of the need, we had to implement this project very quickly. So if you look at the timeline, this project was actually implemented from the time of the inception of the idea to complete implementation at a large scale. So all of our 12 acute care sites just within 2 weeks, sorry. So within 2 weeks, we brought everybody together, came up with the project design, a process for how patients are going to be receiving care. We developed guidelines, we developed patient education material, communication material, sent out all the communication, presented this project at many meetings. Every platform that we could find, we presented information about this project. So just within 2 weeks, this project was fully implemented at 12 sites. But we did continue to meet on a weekly and even in between basis to refine our processes further. So we were testing as we were going along. And just want to describe the process a little bit, the project or the program and how patients are served. So number one is patients are identified and referred to the program while they're still in the hospital. And so they're referred to the community respiratory services team. Patients do have to consent, and after they give us the consent, patients are enrolled, and then they're discharged from the hospital, but at that time they're provided with education, and they're also given a pulse oximeter so they could monitor their blood oxygen levels. And patients also receive education on what to expect at home. And then after, when patients end up going home, there's a clinical assessment that takes place. So the RT, respiratory therapist, will visit the patient in the home to complete an initial clinical assessment. And after that, patients are followed up on a daily basis through phone calls, or some patients, depending on their concerns or symptoms, patients are asked to log in their symptoms into the TELUS remote monitoring technology. And so if, based on the symptoms and patients' needs, either daily home visits are occurred or patients are followed up by telephone. So there's daily monitoring and there's regular communication with the patient's primary care providers in the community. And patients are additionally supported by the Fraser Health virtual care nursing team. And then for after hours, patients are given the 811 number. And patients are also instructed to come back to the hospital should their symptoms worsen. So if there are any concerns that the patients are not able to manage on their own, we ask patients to come back to the hospital. And then patients are discharged once they no longer require oxygen. And then some of the patients, they need oxygen on a long-term basis, and they're just reverted back to the regular community respiratory services oxygen therapy program. So they're not under the COVID Care at Home program. So that's kind of the process that we're using for COVID Care at Home. So my focus was the evaluation. In regards to evaluation, we came up with some questions we wanted to ask. Number one, is the program achieving its objectives? So is the COVID Care at Home program safe and effective in managing the care of COVID-19 patients who require oxygen support? Are unnecessary readmissions prevented? And number two was focusing on the patient satisfaction. So what is the patient satisfaction and experience in taking part in this program? And then the third, our focus was on the provider experience. What is the provider experience in COVID Care at Home? So we wanted to understand the respiratory therapists who were providing the care. We wanted to learn about their experience in regards to their interactions with the clients that they were serving, and how prepared they felt during the program in regards to education and training that was provided to them. So in regards to the type of data we collected both quantitative and qualitative data. For quantitative, we looked at the patient demographics, looked at the hospital length of stay, and the length of stay on the home oxygen program. We also, for our Fraser Health internal purposes, we looked at the types of hospitals or which hospitals were referring the patients to the program. And then we would follow up with those hospitals in regards to the number of referrals they were sending, or if we were not getting enough referrals, we would provide more communication and implementation support to those sites. So that was just something we monitor internally. We also looked at the readmission rates and mortality rates. For qualitative data, we looked at the patient experience. We did some satisfaction surveys, and then we did some provider experience surveys with the RTs. And here are some results. And because the project was implemented at such a rapid speed, we had about 3 months to collect the data for our evaluation. So the evaluation took place between May 2nd and August 2nd. So that was 3 months. During those 3 months, because we were also working on refining our processes and providing further communication to people, we had served 37 clients. Only 2 people declined. And altogether, we had 10 females in the program and 27 males. The average age was 52, with a range of 28 to 69 years of age. And then when we looked at the hospital length of stay, that was 23 days before they were transferred to the COVID Care at Home project. And the total days on the COVID Care at Home program was 16 days. But then some patients needed home oxygen support on an ongoing basis, and that length of stay was 43 days. So overall, in the first 3 months, we had successfully discharged 19 patients, and only 1 patient was readmitted back to acute care within 30 days. And there were no deaths while during the evaluation phase. And we also did some estimates on cost. So just for the 16 days for the 19 patients, we didn't look at the 43 days because that was the regular community respiratory services process, but really the intense time when the patients were receiving care. So that was more like hospital type of acute care like care. And those were 16 days. And when we times that by 1,200, an estimate of $1,200 a day per hospital bed, the cost savings were $710,400. So that was just a rough estimate just for those 19 patients who were discharged. But you could estimate, for 37 and more clients we've served up until now. So huge cost savings as well. And the patient's experience survey, when we did online and phone call surveys because the online response was low. When we asked the patients how they felt with the amount of support they received, 93% felt that they were satisfied. 73% patients felt prepared when they left the acute care sites. 100% of the patients felt they would re-enroll in the program if given the choice. Many patients were very thankful for the services, and just having the option to recover at home was something people were very grateful for, because otherwise they would have spent weeks in the hospital. And 100% of the patients said they were satisfied with the program. And here are just some comments from patients. I'll just read a couple of them. When I left the program, I felt mentally prepared, but not physically prepared. The program was very helpful while recovering, and I will join again if something like this happens again. Just want to say thank you for all the support. I really appreciate it. Just overall, patients were just very grateful, as I mentioned, for the support, for the daily checkups that they were receiving from the respiratory therapist. We did ask them whether they had experienced any challenges. Most of the challenges were just related to anxiety and their ability to do their daily activities because they were still in the active recovery phase of COVID. But not a lot of concerns were expressed about the program. And we did a survey with the providers as well. 6 RTs responded. 100% of the RTs felt that they received enough education and training. And most had 5 out of 6 RTs had positive interactions with the program patients. And 4 out of 6 RTs were satisfied with the program. Some of the challenges that they discussed or expressed were related to guidelines and instruction changing. And that was because, first of all, we were still learning more about COVID and COVID procedures and processes. And secondly, because we were doing PDSA cycles with this project, so we had to change the guidelines quite a bit as we were going along. So there were some frustrations with just the number of times the guidelines had to change. And then we had some staffing issues because of the congestion and the number of patients we were seeing. Some of the RTs had to be deployed to acute care sites. So we experienced some staffing issues. And then the eligibility criteria had to change. In the beginning, it was too lenient, and then we had to restrict it a little bit, but then it became too restrictive, and that many patients were not able to be referred. So we had to keep on changing the criteria as well. And then for some patients, the daily phone checks were just too redundant. They seemed redundant because these patients were quite stable. And then the RTs had provided some suggestions as well that we incorporated and refined the program further. And then in summary, I'll just share some lessons. We had many lessons that we learned. So number 1 was about communication and partnerships. Because this project was implemented at a rapid speed, at a large scale, 12 acute care sites, communication and collaboration and partnerships with all the key teams, acute teams, community teams played a huge role. So we basically used every communication channel that was available to us. And then having physician partners lead and support this project was very, very valuable. The physician partners were able to champion the change, and they were directly involved, not just in the operational project management side of things, but they were also assessing the patients and referring the patients and discharging these patients at the clinical side. So that was hugely helpful. Clinical resources, we had some issues with the GP coverage. The criteria that we had listed included that we wanted the patients to have a primary care provider, and not every patient had a GP, and not every GP was interested in participating in the program. So that was challenging, but Fraser Health has urgent primary care clinics. So we were able to utilize the urgent primary care clinics to provide follow-up care to patients who didn't have GPs or NPs in the community. And RT staffing, as I mentioned, we had some issues with the respiratory respiratory therapy staffing. For that, we were able to work with our virtual health nursing team. And so they were able to support some of the home monitoring assessment and education provision to patients. And then clinical guidelines. So as I mentioned before, the guidelines had to change many times. But in the end, we learned that the processes we need to tailor the care to patients. Not every patient needs a daily follow-up care. So we did make some changes based on that as well. And the criteria, because the criteria in the beginning, were limited. So we had to make some changes to the criteria as well. And as of now, because we determined the safety of this program, and this COVID care program has been merged into regular operations in our community respiratory therapy services, which means any patient who's currently in the hospital, COVID-19 or not, would be eligible for this service, COVID care at home, as long as they need home oxygen and they have a telephone access. So we've made a lot of changes to our processes as well as the criteria. So those were some of the lessons. And I'll just stop here. And I just want to thank you for listening to this presentation and allowing me an opportunity to share this project with you.
Thank you so much, Harveer, for that. I should have mentioned we are a friendly bunch. And so we're into quality improvement too. There is like quality improvement, evaluation, research. It's all about being a learning health system and doing things better. So thank you so much for sharing that. I know access and flow was such a huge, still is a huge issue. So so cool to see something and to hear that it's like operationally, it was a success, and now it's something that is stuck around and is being implemented. Amazing. I'm gonna ask Adrien, I think you're up next. So Camille, does she have the ability to share her screen and all that good stuff? Yes. So maybe get your presentation up. And again, everybody will save some questions till the end, but thank you, Javier, so much.
All right, before I start presenting, can everybody hear me all right?
We can hear you.
All right, perfect. So let's get this screen. Oh, and can we see that just fine?
Perfect. You were nailing this. You've got this.
That's a good start. That's what I like. All right. So thank you everybody for having me here today. My name is Adrien Jiang. I'm the project coordinator for the nurse practitioner team in Fraser. And I was supposed to present with my colleague, Jessica Kromhoff from the virtual care team, but she unfortunately couldn't be here today. I'm here to talk about our research study examining nurse practitioner experiences in delivering virtual care during the COVID-19 pandemic. So I'm going to walk you through the amazing colleagues that I have on my research team, our funding, the background to this study, our research question, what we hope it'll contribute, and our objectives, as well as a bit of an explanation of our methods, our study activities to date. And we're excited to share some of our findings from initial data analysis and our learnings. So I also just want to acknowledge that I'm super grateful to be here. We had a chance to present the design of our study at Research Week last fall, and we're excited and grateful to be invited back here to share some of our initial findings. Once again, this is a research team with Jessica Kromhoff as our principal investigator. And this is a collaboration between UBC Professional Practice, the Department of NP's Virtual Care, and the Learning, Research, and Innovation team. So it's with Laura Houston, Kathy Scarborough, myself, Jacqueline Perr, Michael Tantonko, Marlene Burrows, Kirsten Hudson, our amazing NP student from UBC, and Pavin Graywall, who's one of our NPs. So this study has been funded by the SEED grant through, again, Professional Practice and the Department of Evaluation and Research, and Fraser Health Innovation in Virtual Health. So we know that virtual care isn't new to healthcare, and it has been utilized for many years. But as we all know, that there was a really rapid uptake of this due to the pandemic. And at the beginning of the pandemic, there was limited education on virtual care in NP programs and Fraser. And the literature focused primarily on the patient experience, not so much on the provider experience. At the time when we started the study, there were no known Canadian studies on this topic, and there were no virtual health policies in Fraser or professional standards. And we know that shifted since then, the last couple of years. So our research question is, what has been the impact of the integration of virtual care delivery on primary, specialty, and acute care NPs during COVID-19? Why is this important? Well, we know virtual care is here to stay. This is a time of tremendous transformation in healthcare, and NPs will be required to provide virtual care on an ongoing basis. And so we will expect, NPs will be expected to be equipped with the knowledge, skill set, and comfort to provide the service. So through this research, we want to be able to support current and future NPs in providing virtual care. And we hope that the study will really fill the gap in the literature relating to this topic, especially from the provider perspective, so that we can move forward and further establish virtual care and improve the virtual care experience, both for patients and providers alike. And big picture wise, to inform curricula, clinical policies, professional standards, and practice supports, anything related to virtual care services. So we have 4 objectives related to this study, which are to investigate the experiences of NPs required to utilize virtual care during the COVID-19 pandemic, to investigate if the practice of NPs has been challenged through the use of virtual care as a primary assessment modality, to investigate what perceived knowledge and skills are required in order to effectively use virtual care methods for patient assessments, and to inform future research relating to NPs and virtual care. So this was a mixed method study. We started off with a survey consisting of some demographic questions just to get a sense of how long our NPs have been in practice for and what practice settings they may work in. We had 7 questions comparing NPs' experiences with virtual care before and during the COVID-19 pandemic, 10 questions on their overall perception of virtual care, and 6 open-ended questions. And our survey tool was based on an existing framework that the virtual health team was using, and we just modified it to fit the research question a bit better. And we are also going to be conducting interviews and focus groups, and we're just moving into that stage now. So for our analysis of the qualitative data, we will be using interpretive description, which seeks to understand the contextual aspects of the phenomenon we're looking at, which is delivery of virtual care services during the COVID-19 pandemic. And hopefully this will help us explore meanings and explanations that may impact NP practice. So some of our activities to date are listed here. So we started working on this in the summer of 2021, or maybe even late spring. And after after a series of meetings and conversations around how we wanted to approach this, we put our ethics application through and received our approval in mid-December. And shortly after, we got a letter of authorization to conduct research. And on December 21st, we launched our survey via checkbox and left that open over the holidays. And we noticed at the time that our responses were a little low. So in an effort to boost our response rate, we introduced a draw for the Nurse and Nurse Practitioners of BC Conference registration vouchers for our NPs. And just recently over March and April, we did our initial data analysis. And just this past Saturday, we closed the survey. So now we're moving into the final analysis of the survey results, and we will be we'll be holding our interviews and focus groups soon, with our first interviews starting in 2 weeks. So we're just sharing some of the findings from our survey data. So again, our initial responses, and we're still in the process of analyzing anything else that we may have received after this first round. So at the time of this particular analysis, we had 31 nurse practitioners respond to our survey. And you'll notice for this particular question, I used virtual visits for this percentage of my clients. Pre-COVID, almost all participants used virtual care for just under a quarter of their clients. And during COVID, this really shifted. Half of the participants provided virtual services to 51 to 75%. And we had identified 3 NPs who switched to this modality, pretty much either 75 to 100%. We also asked about what apps NPs used to provide virtual care services before and during the pandemic. And you'll see here, before COVID, telephone seemed to be a popular modality among the group. And during COVID, there was uptake of other apps such as Zoom, Skype, WhatsApp, FaceTime, and other video conferencing apps. And one person identified Microsoft Teams as a modality as well. And 11 of the NPs we surveyed said that before COVID, they just didn't use anything. So for the statement, I was given clear instructions and training on how to have virtual visits. We asked our NPs to rate their level of agreement with this. So pre-COVID, 20 out of the 31 participants either strongly disagreed or disagreed that they were given clear instructions and training on this topic. And during COVID, as you can see from this graph, there was really a mix of responses, with 11 NPs each disagreeing or agreeing, and some were unsure. So no NP, as you can see, said this was applicable during COVID, in contrast to the 3 NPs, I want to say, who perhaps just didn't need to use it before the pandemic. For this next statement, I feel prepared to provide virtual care. Pre-COVID, again, a mix of responses of how NPs felt just all across the board here. And during COVID, more than 3/4 of the NPs agreed or strongly agreed that they felt prepared. For the next statement, I'm able to provide the same quality of care virtually as I do during in-person visits. Again, pre-COVID, we have a mix of responses. A third of respondents either strongly disagreed or disagreed with this statement. And during COVID, again, about a third agreed or strongly agreed that they are able to provide the same quality of care to their clients. And a little over a third were unsure. So this is going to be really interesting, and we hope we can explore that in more depth during our interviews and focus groups. But overall, which this is kind of pleasant to see, almost everybody agreed or strongly agreed that virtual visits are a good way for them to connect with their clients, with a couple of NPs kind of being on the fence about it. Just some high-level summary of some of the open-ended questions that we asked. So some key themes that emerged. So what barriers are you experiencing to providing virtual care services? A number of NPs really identified IT infrastructure as a key barrier. Like, for example, not having like an eFax function available, equipment, so whether it's a headset or adequate speakers or enough monitors to conduct their visit. And some identified privacy concerns too, including whether, for example, how do you know if a particular phone number you're provided is safe for leaving messages in. And some NPs also identified that the need for physical exams is a barrier. And again, we hope to explore that more. With the next question here, are there patient populations to whom you're not able to offer virtual care services? Several NPs were kind of on the same page about this. So some of the populations identified were elderly patients, homeless populations, patients without access to technology, English language learners, patients without social supports, or patients with other conditions such as those who are hard of hearing, cognitive challenges. And interestingly, a couple of NPs said youth as well. And for the final question, what supports do you need, if any, to provide virtual care? This kind of ties in with a question regarding barriers they were experiencing. So advocating for better equipment and making sure that's in place, ensuring there's reliable and secure technology to facilitate a virtual visit. Some NPs identified the need for multidisciplinary team support. So for example, your workflows with the MOA at your clinic to ensure that a virtual care visit can take place, or having colleagues in the community who perhaps could see your clients in the event that you couldn't, if they needed an in-person assessment, for example, and employer-supported training and education. Some of our learnings, we just want to recognize, of course, that this is happening during a pandemic. We're not quite out of the woods, and it's still very much something that our NPs, of course, had to juggle. Extended timelines related to the research process. We were hoping to complete our study by March, which was quite ambitious, and we've had to extend that due to various things like vacation time among our NP group, and just having to amend certain questions, etc. And we also want to recognize that this probably also contributed to a shift in our NPs' skills, experiences, and perceptions over the duration of the study. So, for example, when we launched the survey, we could have had a new grad participate, and by the time we get to the interview, their experiences may have changed. And we really want to explore that. Of course, competing priorities, both for the research team and participants, just balancing clinical demands and our staff's wellness with participating in surveys. This is also related to the fact that several other studies were open to our NPs alongside ours. And of course, operational impacts. And the research process for us is virtual as well, and we will be facilitating our interviews and focus groups over Teams in keeping with the theme of the study. And just overall an appreciation for the research department. We had to send in lots of addendums for ethics approval, and even just little things like a spelling error, extra gaps, and how we word certain questions. Like that fine attention to detail, we were really careful about respecting what we were approved for, and we're super appreciative that we've had a supportive team to work with over in DERS. So thank you very much for holding our hand through this process. And that concludes my presentation. So of course, I understand questions will be held until the end, but if you would like more information, please feel free to contact myself or Jessica. We're happy to answer your questions. Thank you.
Thank you so much. That's another shining example of you see a gap, and so you're working towards finding new information to help improve things going forward, because you're right, virtual care isn't going anywhere. So, and I love that it wasn't just a perfect story that was like, yeah, everybody loved it. I love that there's actually like some further information and questions that you need to answer to sort of to figure that out. So thank you so much for that and for presenting today. We are going to pass it off to Nicole. Another group, the Infection Prevention and Control Group, they haven't been busy at all during the pandemic.
There we go. See if I can make this full screen. Perfect. Well, thank you for the introduction. And yeah, like Kate mentioned, my name is Nicole Shum. I'm a coordinator for infection prevention and control at Fraser Health. And we've been doing some really cool work, really stemming from COVID, but creating a research program within our department to really be able to extend and share our experience working in infection control, and both within Fraser Health and beyond the organization. So this project kind of started with a need and a request from kind of the IPC, from executive as a department to prioritize knowledge translation and expand research, expand the reach given IPC's experience in learning. And most notably, IPC's done a lot of work related to COVID-19 and additionally CPO, which is very unique to our healthcare system. And it's important that we share that work more widely, and sharing that work would also provide more meaning to IPC's work by creating more impact through knowledge translation and increase IPC's visibility within Fraser Health, as well as externally in the long term. And previously, IPC hadn't really prioritized sharing externally, so this was something that we wanted to explore. And kind of overall, we kind of came to this realization that an internal IPC research program and knowledge translation strategy would really help support staff to complete and share research and their quality improvement projects. So our current team has kind of the field experience, but we were asking, well, how do we translate that experience into project to share? How do we achieve this? And kind of what are the barriers to kind of getting to that end goal? So we found at the beginning, the barriers to research and QI projects in IPC mainly revolved around kind of three things: staff familiarity and comfort with the research and QI processes, perceived support for knowledge translation. We found that staff didn't really realize that research and knowledge translation work was encouraged by our leadership. And then finally, not really knowing how to incorporate knowledge translation work into their day-to-day tasks and projects. And so given the needs and understanding these barriers, we were then able to develop a research program that seeks to address these barriers in a hopefully kind of a systematic way, which was the goal. So how did we end up developing this research program? So our ultimate goal for program development, besides actually kind of having staff do the research work and knowledge translation work, was to articulate the research program in a way that was meaningful to staff. And this included work such as developing logics models to speak to staff who will be participating, developing frameworks, developing tools, developing resources, and outlining processes clearly, and being able to communicate those processes effectively. And we really wanted to emphasize that within kind of, especially during this rollout of this program, we wanted to emphasize that staff should really be focusing on work they're already doing in their day-to-day to start. So a lot of our staff already participate in a lot of QI projects, rather than creating what we kind of think in terms of traditional academic research from scratch. So the next step, we did a bit of stakeholder engagement. So we talked with our internal stakeholders within Fraser Health. And we started with our IPC team to understand those barriers, as well as the research interests of the team. I also spoke to DERS for guidance and their insight about how to develop a research program from the ground up. And then we developed a research working group within IPC to provide feedback and insight on drafts of our processes and structures to kind of make sure that those tools were tailored to our staff's needs. So, and with all that came kind of our process development and identifying the needs and requirements of the processes that ultimately were going to help guide this work. And kind of previously, there was no, like I said before, there was no research or QI project processes at the administrative level within IPC, and there was a need for processes to create the ability for IPC to kind of track projects, approve projects at the administrative level, and have budget control and be able to write those projections. And it was important that these processes be low barrier and easy to access by all of IPC, no matter individual experience in research or QI projects. We also wanted the processes to be to encourage cross communication between research and QI project leads, managers, the research working group, as well as leadership. So identifying these user requirements resulted in final frameworks, processes, and templates to help facilitate research and QI project work. And currently, what we have so far is a lot of these tools include like a written notice of intent, a project proposal, administrative approvals document for providing departmental funding. We also developed a flow chart, an algorithm to take staff from beginning to end of a project. And then coming soon, we are working on currently a QI toolkit, a stakeholder engagement strategy, further development of our knowledge translation strategy. And we've also developed a science communication workshop for our staff to really help them think about what they would like to kind of share. So after we've developed our processes and our frameworks kind of thus far, we tested the tools and processes on a few projects to move forward. And some of these goals of this kind of beta testing phase was to have some staff gain experience with the program as well as the processes, get a sense of how the uptake of the program will work, provoke curiosity of other staff sharing their work, gathering feedback about the program to improve processes, as well as identify gaps where tools or resources may be missing, and further understand the needs of our program users. And lastly, we developed a reporting schedule to make sure that IPC leadership was informed of the program's research and QI progress, which also kind of helps us, which helps provide accountability and acts as kind of a feedback loop for the program as in its entirety. And the program aspects we report to leadership include kind of the current projects that are going on, different conferences or publications that projects have been accepted at or aiming to share at, and potential costs associated with those conferences and publications, being able to project. So through all that, the IPC research program is definitely still an ongoing initiative, and it's still developing. We've only been at this for less than a year, but we've learned a lot through the process of developing a research program from the ground up. And I think that took a lot of consistent reflection. And even though the project's still in its first year, some lessons that we've learned from taking this on is that we can't do everything at once. This really forced us to plan and prioritize, making sure that we need to start with current work that we were working on, making sure it was kind of a smaller scale before we kind of branched out into like full-blown academic research or full manuscripts or that kind of thing. So we were focusing on smaller abstracts, smaller scale presentations, and then kind of build from there into more larger scale knowledge translation efforts. There was also a need to be clear on what the expectations were for leadership. So although publishing was the original request, this alone would maybe not get our practitioners involved, our IPC practitioners, and may not build long-term capacity for ongoing knowledge translation. Obviously had to also consider resources and time and all that stuff. We also learned that there needs to be a leader or a champion that takes and provides accountability, somewhat of a point person. We need to engage people that are already engaged, and we found that the curious are going to follow. And we also learned that we need to walk with people to help them achieve what they want to achieve. So being able to provide support, resources, tools, while they learn the process of the research and knowledge translation. And we wanted to acknowledge that everyone would be at different points in their own research, QI, knowledge translation journey. Leadership communication plays a key role in change management. And so because this program requires explicit permission, approvals, and balance from leadership, we needed leadership to also help build momentum in addition to kind of the research program's kind of leaders, as well as the staff actually doing the work. We also learned that we need to start with a why and appeal to various motivations, whether that be the promise to present, the promise to publish, or someone just wants to take on a project. And then lastly, we need to be afraid and don't be afraid to try and just do. Which is exactly what we did. And it was a very daunting task, but we started and we had to find the momentum. And eventually everything just kind of fell into place. Yeah, and that's where we are now. And thank you so much for listening. If you have any questions, comments, you can also contact me, or I guess asking them in the next little bit.
Excuse me. Oh, I haven't talked for a minute. Thank you, Nicole, so much. That is hearing the work that the IPC team has done. It just is incredibly inspiring to me, and kind of like, I secretly want every program and department across the health authority to do this. Like there's sort of a tagline going around that research is care and care is research within the health system. So I love that your whole group is working towards implementing research QI knowledge translation in the day-to-day work that you do. So that is brilliant. And thank you so much for sharing. That is great work. I'm seeing that there may be a couple questions in the chat. Camila, do you have sort of an eye on that and who they might be directed to?
Yes, so there is definitely one question in the chat from John.
Okay.
And it's for Adrienne, and it was asking, was there a representative rural population included in the study?
If you meant if we had any participants from rural communities, we certainly did, for sure.
Does anyone else have any questions for our presenters? Oh, Mike, your hand is raised. The floor is yours.
Thank you. Thank you. Thanks for a wonderful presentation from all three presenters. For Harvey, in terms of demographics, did you see any sort of differences in ethnographic difficulties and problems?
Hi, that's a really good question, and we wondered about that. Our timelines were so fast that we weren't able to study that further. So we just looked at the ages and their gender, and we didn't really get an opportunity to dig deeper. But if we were to able to do a research study, that's something we definitely would be studying. That.
Yeah. Okay, since you're on ages, what about ages? What differences did you see there?
I think I listed some of it, but it was mainly, the other issue was that the criteria initially, and I think now if we were to do a study, we would have different conclusions. In the beginning, our criteria was based on just looking after very stable COVID-19 patients who were on the road to recovery. So the age, if you look at it, we had the criteria had mentioned that it was patients under the age of 70. So, but I think if we were to study this population again, all the patients who we are serving now, we would notice that there's a huge differences in ages. So older patients would be at a greater risk versus younger, more frail patients. I think there are so many other opportunities to study this population, the demographics, what the differences are. So at this time, we just don't have a lot of data because it was a very carefully selected population sample.
Good, thanks. And just quickly for Idreen, you talk about skills for the NPs. Were those skills able to be provided so that they can increase patients' service?
That's a really good question. And so in our survey, we kind of just kept it broad as skills. And we noticed that nobody really elaborated on what those skills were in the open-ended responses. So we are going to make a point to try to discuss that during the interviews and focus groups to probe a little bit deeper.
Good, I think that's important since virtual care, as you indicated, is here to stay. So we need to get those skills going.
For sure, and yeah, oops, sorry.
Good, well, thank you very much. And it's nice to see you, Kate, and nice to see you, Camille. And I think someone else is there that I know. It's Magdalena. I think she's here there too. Good, great presentations. Keep the good work going.
Always a pleasure to see and hear from you, Mike. We love that you come every time.
And congratulations on your master's.
Are there any other questions for our presenters? Oh, everybody's silent. And because I'm a stickler for time, so you guys are off the hook, so you're welcome for that. Because I am a stickler for time, I like to stick to schedules. I know that there is another session. I think, Camille, you might have put the link in the chat already.
Yes.
I think it's hosted by Island, and I think it's another COVID session, but in relation to vaccine research. Do I have all that right? Have I lied to anyone? No, Camille says that I've said all the right things. So I highly encourage everyone to gently leave this one and go on to the next one and continue to learn and share with us all the great work that's being done across all the health authorities. So thank you so much to everybody. Have a beautiful day. Thank you, presenters. Thank you, Camille. Thank you, Mike. Thank you, everybody.
Thanks, everyone. That was great. We'll see you at the next session if you're registered.